Hello and welcome to this, the 25th edition of the Royal Society of Medicine's COVID-19 series. Today our topic is COVID-19 and thrombosis. My name is John Willan. I'm a consultant haematologist working at Wexham Park Hospital, but also at the Oxford hospitals, where I perform research on thrombosis. I'm delighted and honoured to be joined today by Professor Beverley Hunt. She's Professor of Thrombosis and Haemostasis at King's, Consultant of Thrombosis and Haemostasis at Guy's at St Thomas's. She's the author of countless publications and guidelines and the co-founder of Thrombosis UK, the charity. She's recently received an OBE for services to medicine. Welcome, Professor Hunt.
Thank you.
So we as clinicians have a difficult task in responding to COVID-19. Much of the evidence that we would like is not there, and it's coming through from case series. There's a definite lack of high quality evidence. So it's our challenge, therefore, in this seminar to try and think about what is known so far about the risks of COVID-19 and thrombosis, and to consider how we might try best to look after this group of patients. So there's been a lot of concern that patients with COVID-19 are at increased risk of thrombosis. Now, historically, we expect to see in patients with severe illness in ITU a rate of approximately 2/3 of the thromboses will be DVT and 1/3 will be PE. Is the pattern in COVID-19 patients that are seriously unwell the same as this, or is it different?
So what we know about the viral infection is that when somebody develops pneumonia and they have to go to hospital and receive oxygen, they have a profound prothrombotic state. And we know that they've got really extraordinary inflammation in the lungs, lymphocytes and macrophages there. And there's a huge cytokine storm, and that is making the patients very prothrombotic. I don't know what you've seen, John, but I'm seeing people who've got fibrinogens of 10, even 14, which is incredible in so many patients. And so because they're so prothrombotic, we are all thinking that they're going to have a very high rate of venous thromboembolism. And I think in some ways we've been a little bit caught out, because when we looked, as you say, they seem to be much more pulmonary emboli than you'd expect when you look at the number of deep vein thrombosis. And I think that we've been caught out by the fact that we are also, when you do a CT pulmonary angiogram, also picking up immunothrombosis. So we know that with this profound inflammation, we are getting areas within the lung where we're getting small vessel thrombosis, and that will cause a little bit of damming back. And you probably pick that up as a segmental or subsegmental PE, except it's not. We call it PE, but it probably isn't on a CTPA. And when you look at some of the case series across Europe, almost all of the PE are actually segmental, subsegmental, suggesting that actually we are overestimating the rate of venous thromboembolism. So does COVID-19 bring a higher rate of thrombosis than other patients in critical care? Yes, looking at overall all of the critical care patients, I would suspect so. But is it higher than other viral pneumonia? And I think back to the H1N1 epidemic, there were very high rates there. So I'm not sure whether we're saying incredibly high rates or this is what we should expect for a viral pneumonia. And I think we need to remain cautious about how we talk about it. And the other problem is the literature is doing little snapshots of patients whilst they're in hospital. So the clock paper, which comes from Leiden, and the middle dot paper from Amsterdam, and our paper from Guy's and St Thomas's, we're looking at the patients for 1 month whilst they're in critical care. And we know that with hospital-associated VTE, that we need to count the period not only when they're in hospital, but for 90 days afterwards. And that is hospital-associated VTE. And we know that actually 60% of all hospital-associated VTE occur after discharge. So we haven't got a feel and know the exact numbers of cases we're seeing until we have a little bit more data down the line.
Thank you. And if I could just pick you up again to talk perhaps a little more about this immunothrombosis. I mean, just to draw it out, this is a kind of a different phenomenon, really, isn't it? Because pulmonary embolism, the clot will form in the legs and then migrate to the lungs. So we're talking about something quite different, aren't we? The formation of clot within the lung itself, the immunothrombosis. Is this something which we know to exist as a major problem in other viral or other causes of pneumonia?
So I think that we have to remember that inflammation has many endpoints, but one of them is thrombosis. And if we think about other disease paradigms such as Becher's, where you get thrombosis and you treat with anticoagulation, but you know the best way to treat the Becher's is to reduce the inflammation, as people do nowadays with biologicals. And the other is the vasculitis disease, they called small vessel thrombosis 2. And again, we treat with anti-inflammatory. So I think this immunothrombosis that we're seeing is a product of inflammation. And I think we're all terribly excited about the data coming from the recovery trial saying that dexamethasone is effective in reducing mortality, presumably by reducing inflammation. And I'd like to know whether it's reduced the amount of immunothrombosis seen. I know that that is a question that's being asked at the moment.
Yes, I agree. It will be very interesting to see as the data matures. Do you think the thrombotic risks of COVID-19 are predominantly localized to those with the most severe COVID infection, or do you think this increased rate of thrombosis is seen across all patients of all stages of COVID-19?
So we've got different segments, haven't we? So if you get the infection and you may not be very well and you may stay at home, and I think in that period of time, if you don't get enough exercise, if you get dehydrated, you might be at slightly increased risk of venous thromboembolism. And then we've got another group, and I was thinking about this yesterday, some people who probably had COVID pneumonia and never came to hospital, or they came to hospital but they weren't quite hypoxic enough and they stayed at home. And we are seeing a few cases of VTE down the line from them. And then we've got people who are in care homes who we know had COVID pneumonia. And the question is, should they receive thromboprophylaxis? And I can't see there's much difference if you're in a care home and you're not admitted to hospital, but you've got COVID pneumonia from somebody who is actually in hospital. So we've got those groups, and then we've got the post-discharge problems. And I think with COVID, if you go on a ventilator, it's quite a prolonged period. I think the average length of time on ventilators is about 10 to 14 days. You lose a lot of muscle bulk. You need to be rehabilitated when you go home. You've still got that inflammatory state. So national and international guidance is talking about giving these patients extended thromboprophylaxis. That is a couple of weeks of either low molecular weight heparin or off-license use of low-dose DOACs in those patients, because we don't know whether they might be at really high risk of VTE. And we need a trial here. There is one that's being looked at the moment by the CMO. Hopefully that'll get approved, and so that we can work out whether we need to give extended thromboprophylaxis to that group of patients.
So perhaps we can think for a little while then about thromboprophylaxis. Some units are using Ddimer levels to guide their decisions about what doses of thromboprophylaxis to give. Do you think this is the right strategy?
I don't understand it really, because for me, the problem with the Ddimers is that it's not measuring clot, we know that in patients who have pneumonia, they will have very high levels of D-dimer. And why is that? That's because the pneumocytes themselves can produce urokinase, and the urokinase is trying to break down the fibrin deposition that's everywhere in the lung. It's really the hallmark of acute lung injury. So a lot of the D-dimer, I suspect, is spillover from the lungs. And so the early paper from Willan that said, oh, D-dimer is a good marker of outcome, higher the D-dimer, the more likely you are to die, I think is really reflecting the amount of lung injury that is there. And we need to remember that normally, routinely, we use D-dimer to exclude pulmonary emboli or deep vein thrombosis. So negative D-dimer is what we are on the lookout to say, oh, hey, okay, you haven't got a clot. But we know that D-dimers are increased in patients in inflammatory states and post-op and in pregnancy, all these things. I think that it's not necessarily a good marker to use. We've never done it before, so why are we doing it now? So we've always relied on clinical trials and clinical outcomes for thromboprophylaxis. Why use a biomarker that we're not sure about at this current time?
Okay, thank you. So then, thinking in practical terms about what thromboprophylaxis different groups of patients should be offered, I thought we might just think about intensive care patients, and then ward patients, and then those who are positive but are never admitted. Perhaps if we start with intensive care patients, how would you give them thromboprophylaxis? Would you monitor it? Maybe you can expand.
So there's these two schools of thought, aren't there? And I think critical care highlights it. There's the old school of thought, I'm not going to do any change at all until I've got some evidence, which is a very rigid approach, but it's possibly the right one for a lot of people. And then we've got the other responses. My goodness, my patients before me, they are thrombosing everywhere. Beverley, will you please do something? We've got to give more heparin. And so we've got those two schools of thought all the way through the pandemic. There's tensions in how doctors think. And I always think that intensivists, they work on their feet and they react very well to what they see. So they were pushing really hard to push up the doses of heparin. Everybody wants to do the best for their patient, even the group who are very rigid and those who want to do something. There's no doubt about their altruism, but what's the right way through? So we know if we increase low molecular weight heparin, we will probably increase bleeding, but we don't know by how much. And I think that now the guidance has come through for critical care patients to use standard thromboprophylaxis or weight-adjusted thromboprophylaxis, or to push the dose up to an intermediate dose, depending on the local unit, and only to use full dose if somebody actually has a proven venous thromboembolism. I think that using full dose low molecular weight heparin or unfractionated heparin when you haven't had a clot is just a bit too much. So that's critical care. Do you want to move to the ward next?
Just whilst we're on that, some units would recommend monitoring anti-10A levels. Would you be doing things like that to help you, or not especially?
So I'm a great fan of anti-10A monitoring. All the clinical trials that were done in critical care, I mean, there have been 7,000 patients put in RCTs. They didn't monitor the levels of anti-10A, and anti-10A levels they vary a bit between labs and techniques, and we never did a trial to know what level to aim for anyway. So I wouldn't do it unless we had really extremes of body weight, or if we had somebody who had renal failure and they were oozing a bit, probably they need an anti-10A level. So no, don't tend to monitor anti-10A with low molecular weight heparin.
Yeah, okay, thanks. So how about ward patients, people not requiring ventilatory support, but they might perhaps be on oxygen, COVID positive, of course?
So they're all prothrombotic. If we were to risk assess them using standard risk assessment in the NHS England use, they all qualify for thromboprophylaxis, and that's what all the guidance says. If you have got a pneumonia and you're in hospital, you should really, with reduced mobility, you should receive thromboprophylaxis.
And that would be standard dose?
So what do we mean by standard dose? So all the trials were done about the turn of the century, and there are probably about 10,000 people put into the trials of medical thromboprophylaxis. And using standard dose, you reduce the rate of VT by about 50%, which is pretty good. The problem is, at the turn of the century, the average BMI in the UK was about 25, and now it's 28, going up to 29. And we do see a lot of very large people. So I feel that weight adjusted is necessary for the larger folk, and also for the smaller folk. And we really need to trial weight adjusted versus standard. But I think when you see some very large people, you feel you're obligated to give them a little bit more low molecular weight heparin. Do you do the same?
Yes, I think we do. I think we haven't always, but I think we're moving towards the weight adjusted thromboprophylaxis. Okay, and so for those two groups that we've already touched on, the intensive care and the ward patients, which of the patients will you offer your thromboprophylaxis to at home, and which agent would you choose if you do?
Okay, so if they have been on critical care and they've had a long period on a ventilator, definitely, and we have a big ECMO unit, and we'd put all of them on extended thromboprophylaxis, provided they didn't have any bleeding issues or they weren't already on anticoagulation for other reasons. What agent would I use? Well, low molecular weight heparin or a low dose DOAC. And I know it's off license here. It's licensed for use in the States, and we can either use rivaroxaban or I might even think about apixaban, but that's really going a little bit away from standard management and trial-based evidence.
Okay. And what about patients who are well, but who test positive for COVID for some reason through a screening program, perhaps? Would you give any thromboprophylaxis to this group, or I suppose you'd risk assess?
So I know that some emergency units are giving thromboprophylaxis to that group. I think I would be a little bit more conservative if they aren't severely affected, especially if they have something like anosmia, where we know they tend to have a more mild course and they're young. Then I wouldn't bother. If they had other comorbidities, then one might consider it.
There's been some talk in the literature about how heparins may also have this anti-inflammatory effect. Do you think there's much evidence for that? And is that the reason why you're favouring the low molecular weight heparin?
So they also have an antiviral effect. So there's quite a lot of literature showing that heparin blocks the binding of the virus to the ACE2 receptor, just because it sits on the endothelium and gets in the way. And so there are trials of nebulized heparin hopefully coming through in the UK and certainly being done in other parts of the world. Yes, heparin does have an anti-inflammatory effect. It has an anti-complement effect, but how big is it when you compare the profound prothrombotic and inflammatory effect of COVID? And I suspect it just dumps it down a little, and it's not a real major player, but that's something else that's a question we need to answer.
Yeah, and along those lines, perhaps, we have a few questions, but one from Ian Sanderson, who's asking whether patients who are already on anticoagulation are in some ways underrepresented. So is there any evidence yet that it seems to protect them from catching COVID or from perhaps the serious complications?
So we don't know the answer to that question, do we? And one of the issues about if you're already on anticoagulation and you get COVID pneumonia and you come to hospital is how to manage them. I think that most of them should probably stay on their normal anticoagulation, and then if they get that much worse and require critical care admission, they should be switched to a low molecular weight heparin. It's a fascinating question, isn't it? And I don't know the answer. We have had quite a lot of people on anticoagulation being ventilated, but whether they're proportionate to the proportion of people who are already anticoagulated, I don't know. It's an interesting, because I think there's 1.5 million people in the UK who have atrial fibrillation that requires anticoagulation, and there's probably about 1 million people who are on anticoagulation. We've still got that gap that we need to close. So you could do some calculations, I guess, on the back of an envelope, but they haven't been done yet.
Quite difficult though, isn't it? Because
yes.
Those same group of patients will potentially fall into the shielding groups, at least here in the UK, and therefore potentially being exposed to the virus less than others.
Do they? Well, people on anticoagulation aren't shielding.
No, not on itself, but I mean that they're more likely to be an older group who may well have other comorbidities.
Yes.
Yeah. Okay, it's often said that patients with COVID-19, the severe COVID-19 patients, don't bleed. Again, I know we don't have great evidence yet, but what is your experience of that?
They do bleed. So we have looked at our first month's COVID patients on critical care, and we had about 6% rate of major bleeding. That included people who are on ECMO, where we'd expect high rates of bleeding anyway. So, I'm aware of other cases who've had anticoagulation and who've bled. So I think that that's more data that we need to gather, but they do bleed. They really do bleed.
Okay, we've talked so far about venous thrombosis, but just thinking about arterial thrombosis, some of our viewers have suggested whether there may be a role for aspirin here, prophylaxis, to reduce rates. So maybe you can talk a little about whether arterial thromboses seem to be increased and whether there is any role for antiplatelet agents.
So yes, arterial thrombotic rates are increased. We've seen more stroke. We'd expect to see more stroke with any acute infection, and there's also been more MI. Although that data is a little bit more obscure and needs some work. So looking at what happens to platelets with COVID, there's been a few papers recently showing that, like every other part of the immune system and the coagulation system, platelets are very activated in COVID. And whether giving an antiplatelet agent would help reduce thrombotic rates is not clear. So there's a huge level of uncertainty. So there will be an antiplatelet arm on REMAP-CAP. So as you know, in the UK, we don't have any trials of anticoagulation outside the platforms, and we do have recovery looking at the ward patients, and we've got REMAP-CAP looking at critical care patients. REMAP-CAP already has an anticoagulation arm comparing full dose anticoagulation with standard of care, and we are actually at the moment designing another arm to look at antiplatelet agents, and there'll be a choice of antiplatelet agent that you can use, and we will put dipyrimidine in there and aspirin. Clopidogrel, there's some issues with clopidogrel and some of the antivirals that are being used. So just finalizing that, and that will probably go live, I would have said, in the next few weeks.
That's very exciting. We have a number of questions I thought we might turn to now. So one from Paul Boiteau from Alberta, who asks if there's any role for thromboelastography.
So if you do thromboelastography, you'll see that the patients have got a profound prothrombotic state. and very wide maximal amplitude because of the high fibrinogen and the factor VIII. It's that same old question with thromboelastography. How should we use it? And I honestly don't know that it's adding any more to the situation than conventional testing. I have to throw the question back to the questioner and ask how would they like to use it?
I mean, I think its role is probably in research at the moment. I don't think we're really using it in our hospitals to guide management of these patients, but I do think it would be very interesting to screen a lot of patients and see what pattern is emerging.
Yeah.
Yeah. Okay, moving to another question. So Opayemi Babatola from Warsaw is asking whether we actually know that thrombosis is a leading cause of death, or are these thromboses are happening towards the end of a patient's course of a severe infection?
It's a good question, isn't it? We are seeing people being discharged from hospital after severe COVID having VTE. I haven't seen any deaths there, but they wouldn't come to us. And we know that when we do postmortems, some of the patients have died of pulmonary emboli whilst they've been in critical care. And I don't think they've always been at the end of their pneumonia. It has been a sudden event. So yes, I think it is a major cause of mortality in patients with COVID.
Barbara Barton from St Mary's is asking, do we know if there are different risks of thrombosis in different ethnic groups?
So we don't. And the question really is about whether there's a genetic component, isn't there, with the BAME groups, or whether they have the risk factors for COVID more prevalent in their populations. That's not a question for me. That's a question really for epidemiologists, and I don't think we've quite got there yet.
I think we're pretty much running out of time, actually, but just to run through a couple of others. Yeah, thoughts about pre-hospital anticoagulation with DOAC or dolteparin in high-risk groups, so elderly diabetes, high BMI. Yeah.
Probably. So I think if you ask 10 haematologists, you'd get 5 saying yes and 5 saying no. I would say yes, I'd probably give a low-dose DOAC. What would you do, John?
Yeah, I think I would do. I think I would if they had a pre-existing high risk and then we added this on top. It would feel like the right thing. A question coming from Helen Baxter, who wonders whether there's a risk that convalescent plasma may increase the risk of thrombosis.
That's a very clever question, because we know that if you use intravenous gamma globulin, there's a slightly higher rate of thrombosis. And so theoretically there may be, and we'll have to look out for the evidence for that. But we haven't really got far enough down the line with the convalescent plasma to know yet. Yeah.
David Milgram asks whether immunothrombosis may be causing the damage that we see in the kidneys and the gut, or is it some other process, do we think?
So when you look at kidneys and you look at them at post-mortem, looking at all the studies, there's no evidence of a thrombotic issue within the kidneys, and more one of tubular necrosis. When you look at the intestinal issues, it's quite interesting that there's ACE2 receptors on the endothelium in the small bowel, and we have seen patients who have small bowel thrombosis. I think where the ACE2 receptors are is pretty key to why COVID is like it is, because we know that the virus is getting in that way, present on some of the endothelium, such as small bowel, and also present on the macrophages, so really switching them on the lymphocytes. Although platelets don't have a receptor, they have found virus within the platelets. And also adipocytes have ACE2 receptors on them. And so the adipocytes probably are allowing entry of virus, and maybe they're switching on to produce more cytokines. I don't know. Lots of things I can't answer, and I don't think anyone can at the moment, but thank you for that question.
No, great question. Okay, I think we're pretty much out of time, but I wouldn't be doing my job as the chair if I didn't ask you about the guitars behind you, which has been a question asked by several contributors.
So my partner plays in a band, and I'm sitting in a room surrounded by guitars, and I thought it was a much nicer backdrop than my office. So I hope you enjoyed them. I'm told that they are spectacular. I think one of them is the world's most wanted guitar, but I really wouldn't know which one.
Fantastic. Okay. Well, just thank you so much for that fantastic webinar. Just wanted to apologise to the people who've asked questions that we haven't had time to get round to, but to draw your attention to episode 26 of this series, which is on the 30th of June, when a lot of these unanswered questions will be put to an expert panel. So do tune in there. Also, the seminar coming up tomorrow on LGBTQ Pride in Medicine, which is happening tomorrow. Professor Hunt, thank you so much for your time. That's been really interesting, and I do appreciate you taking the time. Thanks.
Thank you.